You're listening to Gender, a Wider Lens.
I'm Stella O'Malley, a psychotherapist in Ireland.
And I'm Sasha Ayad, an adolescent therapist in the United States. Since 2016, my practice has been exclusively dedicated to gender questioning teens and families impacted by gender dysphoria.
I also work with gender questioning teenagers, and I facilitated support meetings for families and individuals who've been impacted by gender issues.
We're curious about the concept of gender and how it's unfolding in the wider culture.
Join us as we look at gender through a wider lens.
Jennifer Lahl is founder and president of the Center for Bioethics and Culture Network. She has 25 years of experience as a pediatric critical care nurse, hospital administrator, and senior-level nursing manager, and more recently, she's also become a successful filmmaker. In 2010, she made her writing, producing, and directing debut with the documentary film Exploitation, which was awarded Best Documentary by the California Independent Film Festival and has sold in more than 30 countries. She's also director, executive producer, and co-writer of Anonymous Father's Day, a 2011 documentary exploring the stories of men and women who were created by anonymous sperm donations. In 2014, she completed 3 films on the ethics of third-party reproduction, also known as surrogacy, with a trilogy called Breeders, a Subclass of Women. And in 2015, she released a documentary short called Maggie's Story, which follows one woman's egg donation journey. Her next feature film, Big Fertility, was released in the fall of 2018. Of course, we were particularly interested in Jennifer's films that focus on gender medicine. Transmission, What's the Rush to Reassign Gender, was released in June of 2021, and her forthcoming film, The Detransition Diaries, Saving Our Sisters, is set to release this fall in 2022. In our discussion today, Jennifer puts forward her theories about what she calls a superhighway that confidently shuttles people towards risky medical interventions. This happens, according to Jennifer, both in the realm of fertility and gender. Fertility is an area that Stella and I know very little about, so it was interesting to hear Jennifer share her experiences as a nurse and as a filmmaker who's obviously followed this topic very closely. She holds some really strong but thought-provoking views on the medicalization of fertility that surely some people will find controversial. Ultimately, though, Jennifer's biggest concern is that any patient, whether they're pursuing interventions in fertility or gender medicine, should be fully informed about the risks involved and the outcomes. She also highlights that sometimes a lack of evidence underlies the model of informed consent. She poses the question, how can you consent to something if we have very little or no evidence about it? So we explored the parallels that Jennifer's observed in these two areas of medicine, both incidentally with really serious ethical considerations around fertility and reproduction. We highly encourage you to check out both of the films she's made on gender, which we also talk extensively about in this discussion. So here is our conversation with Jennifer Lahl.
Hi, Sasha.
Hi, Stella. I'm so happy that we are here talking with our guest, Jennifer Lahl. Thank you so much for joining us.
Yeah, I'm so excited.
Well, Jennifer, you've been really focused on, you were a nurse, you're of course a filmmaker, and you've made a lot of films that have to do with different aspects related to kind of reproduction, reproductive health, and then of course most recently, transition medicine and detransition. But I think your story starts further back when you were practicing as a nurse and starting to observe some ethical dilemmas there. So I'm wondering if maybe we can start back then. Like maybe how did you get into nursing? What drew you into it? And then what did you start to notice while you were working in the field?
Yeah, well, I actually was quite sick as a child. And I, for 1 year, spent 1 year in the hospital. Like for an entire year when I was 10 years old, I lived in the hospital. And the nurses were just great. They kind of put me to work. I got to pass out the snacks at night and bring around the snack cart to all the other kids in the children's ward. And I got to learn about who had to be on a sugar-free diet because they were diabetic and who couldn't have fat because, so I had such a great, believe it or not, I had a really great experience, even though I hated being in the hospital and I wanted to go home. And I thought that just got me really interested in hospital nursing. I had a blood disease. I don't get into the gory details, but I actually wanted to be a medical physician and be a hematologist because of my own personal. But then once I got into college and I realized the commitment for medical school, financial and time-wise, I became because I am very practical. And I just thought, well, I could be very happy pursuing a nursing career. And so most of my clinical nursing was in pediatrics, which is not really kind of funny considering I was a pediatric patient. And it was more focused on pediatric critical care. So I was a peds ICU nurse at the University of California, San Francisco, at University of California, Los Angeles. I kind of closed out my clinical career at Children's Hospital in Oakland, California, where I moved into senior level hospital management, administration. But if anybody who's worked in hospitals as a nurse knows, even if you're a manager, you're still doing clinical practice because you have to relieve people for breaks, and if there's short staffing, you have to step in. And because I was always attached to university hospitals, we were always pushing the envelope. We were the places that were doing the clinical trials, trying out the new procedures. I worked with the doctor in San Francisco who did the first surgery where he took the baby out of the mother's womb and repaired the defect and then put the baby back in the womb so that when the baby was born, it was born healthy. Otherwise, that baby probably wouldn't have had a chance of surviving. And those were cool things. I'm all for those kind of really amazing life-saving kind of interventions. So I'm not anti-technology. But I also, because in pediatrics, you certainly know with the work that you women do, you're dealing a lot with parents and parents having to make decisions. And parents having to make decisions often on the fly, with very short notice. And the burden of knowing that these are people, I will see this child and then they will go on and I'll never see them again. But these parents have to live with whatever decisions they make for the rest of their life. So it was really a burden that I had to make sure that parents were really making the best possible decisions with as much information as they could have and understand. And so I went back to graduate school and I pursued a graduate degree in what is now called bioethics. In the olden days, we had medical ethics, but then, medicine got too paternalistic and the doctor knows best. And so we moved into the space of bioethics, where if you've been on ethics committees, which I've spent a lot of time on ethics committees, it's more of a conversation. You have lawyers in the room, you have hospital administrators, you have social workers, you have, of course, family members. And so ethical decisions sort of move from the doctor to saying what we're going to do and what we're not going to do to, ethics by committee, which can be very good, but it can be very bad depending on who's on the committee and what the values of who's on the committee is. So I pursued, bioethics and got my master's. And when I was in graduate school, I was planning just to go back to clinical nursing, maybe go into teaching in nursing universities and nursing schools. But I just got this bug of all these new stuff that was coming down the pike as it relates to biotechnology, gene editing, making and designing life in the laboratory, cloning. Cloning was the big debate at the time when I was in graduate school. Dolly the sheep had just been born, which was a sheep that was cloned, and all the ethics around what would happen. Bill Joy, who was the lead scientist at Sun Microsystems in the secret Silicon Valley at the time, wrote a very profound Wired magazine essay called, I think, don't forgive me, Bill Joy, Why the Future Doesn't Need Us Anymore, I think was the title of the essay in Wired. And it was sort of alarming the bells around artificial intelligence, robotics, nanotechnology, and being able to make tiny, tiny little super smart machines that we couldn't even see, but were so smart they could self-replicate. So I just got my world just blew up. And so I founded the organization I now run, the Center for Bioethics and Culture. And, we've sort of stayed in, as you say, the space of reproductive technology, but we can talk more about how I shifted into the trans stuff. If you want to talk about that, I'll let you, it's your show.
Okay, so I'm very, very interested in this. So when you say you got the bug, you started noticing these things, were you kind of initially like cheerleaders for these types of technologies, or were you from the beginning a bit skeptical? Or tell us What did you get when you got the bug? What was that bug?
Yeah. Well, again, back to my patient advocacy and my educate. Pediatric people are always educating people. We're educating parents how to take care of the kid when the kid goes home, how to give the insulin, how to mix medication. Education. And I just thought, these are profound, future of civilization things. And shouldn't the public be educated? Because the public are stakeholders, not just, Silicon Valley, not just, big pharma. So my urgency was to quickly, how can I make these really complex things? They're doing what to children? They're doing what in the laboratory? How to sort of not dumb it down. That just seems kind of like negative. But how to make these big things accessible to just regular old people, and to make them interested, excited, alarmed, whatever. People have different reactions to this kind of stuff. But really to shape how we introduce and accept new things into our worlds. We now, I use this as an example, we now have over 1 million frozen human embryos in the United States alone through assisted reproduction. That's kind of an unintended consequence. We've never addressed it legislatively. We've never addressed it medically. Like some other like Germany, it's illegal under federal law in Germany to freeze a human embryo. And I think that's a little bit of, they still remember their past, their medical abuse past,
What is the reason given for that?
Well, because most assisted reproductive technology cycles fail. It's a high failure rate. So people who enter into the assisted reproductive space, either gay couples trying to have a baby, or infertile couples, or Hollywood people who don't want to bother with pregnancy, there's many reasons. We know that this is very expensive technology with a high failure rate. So big medicine, big fertility, I call it big fertility, makes a lot of embryos because it's a lot of money and there's a high failure rate. And you don't want to keep going back and taking eggs out of your body and sperm. It's onerous, it's expensive, it's risky. So we just make a lot. It's not unusual for somebody to have, 20 embryos frozen, because they'll try one and the pregnancy won't succeed. They'll try another. They'll thaw some, and a lot of them, they don't survive once they're thawed. So we just make a lot. Quality control.
So, I'm really interested in this, and I know this isn't directly related to gender transition, but I feel like this leads in. So can you just help me understand? I'm not someone who knows much about the industry of fertility or freezing embryos or anything like that. Just help me understand, what exactly does that mean? How does that work? How do people do this? And why do you think it's such a big industry? I also want to ask about the bioethics of this from your perspective, but just help me and other listeners who are not familiar with these processes. What is this? What are we talking about?
Yeah. Well, there's many layers, and some of it does really line up with what we're seeing in the gender affirming medical model. In the rush to do that, we're very impatient. We're very impatient people. I can't speak to the people in your country, Stella, but in the American, we're really impatient.
We're learning to be impatient from you.
We want quick fixes. And if we have money, we want those fixes to be quick, immediate. And we found a workaround. So fertility medicine's a workaround. We've stopped looking at why people are having trouble with conceiving. And there's many reasons why couples, and I say couples, I'm speaking of in particular heterosexual couples who should naturally be able to conceive. We have obesity, we have, environmental toxins and pollutants, we smoke, we drink too much, we wait too long. We just sort of, we don't take care of our fertile bodies. And I always remind people that, our fertility is really fragile. We're not rabbits. And it's truly amazing when, a baby is born, because there's a million things that go wrong to make that not happen. And once we had the first test tube baby born, which was the famous Louise Brown, born in the United Kingdom some 40 years ago now, we found a workaround. right? And we went, oh, well, when people, and so now it's not uncommon for me to talk to couples who, they're trying to get pregnant for maybe 2 or 3 months and they're rushed off to see the fertility doctor. And 3 months is not a long time to try to conceive. But in our minds, the first thing out of the doctor's mouth, your regular, physician, is go see the specialist. And the specialist is happy to have you on, I call it the superhighway of fertility medicine, because they're going to make a lot of money off of you. So that's a little bit of what we're seeing that with the shifts in gender affirming care for children. We're impatient. We don't want to watch and wait. We don't want to pump the brakes. We want to quickly send them to the gender affirming clinic. And we'll fix that problem like tomorrow. We'll get that kid on puberty blockers and we'll get them on the path to, surgeries and blah, 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 blah. And I've seen that in the women that I interviewed in the movie that's coming out, which we can talk about in a bit, how quickly they were put on, how easy it was for them to get powerful cross-sex hormones. So I think that's a lot of it, is this impatience, this workaround. Why are we no longer spending any of our resources? We already know that women's medical health gets this much of the research dollars compared to other, we're always, clamoring, why haven't we figured out breast cancer? Why haven't we found cures and treatments for things that women have been having for years and dying of? So we don't spend a lot of money, but when we have this really profit motive fix, we just rush everybody there.
No, it's brilliant. It's shocking when it's said so straight that this.
I'm a real drag at cocktail parties.
So am I. I'm honestly the worst. It's so hard to make new friends. I get it.
But you put it as from what I could read, as this is very much a money-driven, profit-making machine, while I would have thought this was a very scientific, what can we do next, curiosity-driven, that is making money, but perhaps it's now I'm thinking about it, maybe the scientists are supported to do the money-making, what can we do next kind of initiatives.
Yeah.
And there's other initiatives which mightn't make them as much money, such as, I don't know, curing different things that mightn't make them as much money, that maybe don't get supported. And that's why we're driven by one and driven by the other. I don't know if that makes sense.
Yeah. And, if you are like me and you've read, you're not like me, so you probably haven't read, like Lisa Mundy, who's a journalist, wrote for Mother Jones. She wrote a great book called Everything Conceivable. Deborah Spar, who used to be the head of Harvard, wrote a book about the baby machine. Gina Correa, a great early feminist, wrote a book called The Mother Machine. Where women were just being treated as guinea pigs by fertility doctors who were, you hear all the stories about creepy fertility doctors inseminating their patients with their own sperm. These women Netflix has had a great film that came out, I think last month or 2 months ago, called Our Father, this fertility doctor in Indiana who was inseminating all of his patients and never ever told them, so there's, I think it was in Mundy's book, she quotes a very prominent fertility doctor in San Francisco who basically said, fertility medicine, it's a paraphrase, but it's basically they're throwing spaghetti on the wall and seeing what sticks. We'll put these women on all these drugs and we'll see if this will help them. We'll do all this kind of intervention, see if that will help them. And you could say the same thing about what they're doing to children. They're just throwing stuff at kids. They don't know what the hell they're doing. They don't know if this is harmful. They have no interest in proving that it's safe and doing studies. And I'm in the backyard of Dr. Turbin out here at Stanford. We've seen what he's able to get published and sort of the mockery that's being made of peer-reviewed science, in quotes.
Mm-hmm.
I'm sounding really cynical and bitter, and I'm really not, but I do get kind of a little bit miffed.
I'm noticing that there's kind of different types of characters who we find when we start to notice that there's maybe some sort of medically or ethically questionable medical stuff going on. Like, I think there are the kind of doctors who they're very arrogant. They believe they're pioneers. They think there's no means that would prevent them from doing this like incredible medicine. They have a bit of a God complex. Like, I think I know those clinicians, and I studied this with lobotomy. We've looked at this with repressed memories. Like there is this character. And then at least I can say with gender medicine, because that's the world I know best, there's like an army of clinicians, a lot of whom are women, who seem to be on the surface motivated by a great deal of compassion and attempting to eliminate, eradicate, reduce suffering. And I don't know much about fertility medicine, but I'm very curious about whether there's a similar pattern there. Like, it doesn't have to be women, but like, OBGYNs or fertility doctors who really think, rather than a couple struggling or being disappointed with their fertility difficulties, we're just going to streamline them towards their goal. We're going to give them what they're looking for very quickly. Like, do you think that there's a version of that too happening in that world?
I don't know, because I see these creepy women that are doing mastectomies on children that are on their TikTok, So I see women. One of my first early films was called Exploitation, and I interviewed several women who saw ads in their university papers to sell their eggs, make a family, make dreams come true, be an angel, blah blah blah. Who were seriously harmed. And one of the young women in that film, the doctor who retrieved her eggs, was a very prominent fertility doctor in the San Francisco Bay Area. And we showed up at a hearing to testify in Arizona State, and that physician was there. And she knew that woman was her patient, and she never even let on as she testified against us in this hearing. Instead of going, I would have been ashamed. I couldn't show up in a Senate hearing room to testify and have this young woman who walked in, and this young woman literally almost died in the hospital after having her eggs, removed from her body because they'd nicked an artery and it went undiagnosed for hours while she laid in the recovery room. She was a medical student, this young woman. So she knew something was wrong. And they kept saying, it's time for you to get back to the airport and catch your plane home. And she said, I can't even stand up and walk, and I'm in so much pain. And then they found out when they had to rush her back for emergency surgery that she'd been bleeding in her abdomen for 6 hours. And they were trying to get her on a plane to get her home. And that physician who removed her eggs was the one that was in the hearing room. And you can't tell me that she walked in, this was several years later, and did not recognize this young woman as one of her patients that almost died. And so I don't know. And when you look at reproductive medicine, it's referred to often as the Wild West. Reproductive medicine is the Wild West. And it's common that, the reproductive doctors are cowboys. It's sort of that, God complex. Here we come to save the day. We're riding in on our horse with guns a-blazing, and we're going to save everybody. So there is a little bit. I see it in women as much as men.
That's really interesting. So you're focused on these kind of fertility issues, and you made this movie, Exploitation. Then when did the gender thing come across your radar?
Yeah, well, I've been following this issue for quite some time, but as an organization, we didn't make a decision to get involved in it yet because we were sort of heavily focused on assisted reproduction, the infertility debate, what we call third-party conception, surrogacy, egg and sperm donation, gene editing, designer babies. You think of all the great movies like Gattaca. You can have the baby of your dreams, and then I became very aware that they were offering minors before their puberty blocking or before they were put on cross-sex, wrong-sex hormones, they were offering fertility preservation. And I thought, wow, they really do want patients for life. The endocrinologists want patients for life. The fertility doctors want patients for life. And again, back to my years of pediatric nursing, I thought, well, there's no way in hell that these young kids can even consent to, I think maybe 20 years from now I'll want children. Yeah, I think, a 12-year-old might even say, what's a sperm? What's an egg? Let alone, sure, let's freeze them and save them. And I just thought, oh, what the hell? And then, of course, it also happened with men having babies. And then trans men and trans women having babies. And then there was a study that came out a little over a year ago that said they interviewed a bunch of trans women who wanted uterine transplants. And uterine transplants is part of our work, whether it be with artificial wombs or synthetic wombs or transplants from one woman into another's body. So our worlds just kind of collided. And like I said to you guys earlier before we started recording, I was in clinical nursing at an era where we were doing the watchful waiting, and we were saying there's really no rush. Once we can find out if there's any underlying, genetic thing that's going on here, or real endocrine kind of a problem, there's really no rush to do anything medically to a lot of these children, and they can just be, left to be.
So are you saying that you worked directly in childhood gender medicine at any point, or you're just saying you were aware that was the standard protocol at that time?
Yeah, that was, because I was in clinical nursing, and that was before the gender, clinics were even a thing. We didn't have a gender clinic at Children's Hospital in Oakland or the UCs. That was pre that. But we would occasionally, get children that were in the hospital for other things that required them to be hospitalized. We did see kids, of course, that were born with, ambiguous genitalia, the Klinefelter, the Turner syndrome. So we would see those kids because they were just newborns, and we would have to diagnose them to find out what they were. But even in those cases, it was, well, we really don't need to assign anything yet, because this child might, as they grow up, it might become more evident how they're oriented. And, are they going to be more feminine, or are they? So I was always mindful of that. If anything, what we saw, again, because it was the hospital setting, we saw a lot of girls that were there for anorexia, cutting, they were just doing kind of harmful things that require them to be hospitalized, which of course we're seeing that now with this, this burgeoning of young girls that, they have histories of depression and anxiety, eating disorders, cutting, self-harm.
What made you come towards the film and the detransition world? Because at this stage, you're at the very much watching young girls.
Yeah, well, I love making movies. I found that out, I'm not I didn't go to film school. People say, How did you learn to make movies? I go, well, I watched them on TV. Isn't that how you learn? I mean, how did you learn things in the hospital? They say you have to start an IV. Here, this is how you do it. Put a tourniquet on, you poke the needle in the vein. People don't read.
I know.
Right? People don't read, right? You open up your inbox and it will say at the very beginning, 3-minute read time. Like, please read this. It will only cost you 3 minutes of your life. And I had a book manuscript I was shopping around to get published. And, it's this hard to get people. We actually just signed a book deal yesterday for the Detransition Diaries. A publisher wants us to turn the movie into a book. So it will be a book. But overwhelmingly, we could get people to watch films. And I was a pediatric nurse, so I was interested in this issue of transing of children. My partner, who works with me, who made both of these films with me, is a labor and delivery nurse. So we're two nurses, we're two women, we're both moms. And we had, and we just thought, well, damn it, we're going to make another movie. And then when Transmission came out, it was clear that the audiences really resonated with the detrans stories. And when we saw what happened with Grace on 60 Minutes and how the outrage and the backlash for how dare you include their voices, and well, they just weren't really trans, that's why they did this, or, there's all that kind of stuff. We thought, oh, there's something that they don't want told. So those are the stories we want to tell, the ones that, they're trying to scare you out of telling, the ones they're trying to discount. And people will watch, Sasha's seen the early rough cut of the film, and you're welcome to see it too, Stella, if you want, it can send you the link. But I think people will just really connect with these young women. They're beautiful, they're poised, they're articulate, they're well-spoken. They don't come across as bitter or angry. They're not blaming anybody. They see what went wrong and where things should have been barriers saying stop or don't do this, but they don't have any axe to grind. So I think the audiences will really connect with these young women and say, you guys are onto something here.
Yeah, and they're very relatable. So you're talking about the Detransition Diaries, the 3 women that you followed there. They're very relatable, and I think they reflect, I often say any would-be gay kid is now being transed, but not all the trans kids are gay. right? So I think these three young women reflect a contemporary narrative that we're starting to wrap our minds around, which is really different from, like, I had gender dysphoria since I was 3. I was always an extreme tomboy. That's not the stories of these kind of ROGD girls. So I think that was really nice. But I want to go back to Transmission. When you made that film called, What's the Rush to Reassign Gender? I'm curious about, did you learn anything surprising in the process of making that film? How was it received? I'm just really interested in that, because that was a really important documentary for just tracking the medical aspect of this and the kind of manipulation that we see in some of these gender clinics towards parents, and chronicling also just what the affirmative clinicians say. I mean, it speaks for itself to hear them talk about the kid is in the driver's seat and the parents are in the back seat. I remember that moment. I mean, just talk a little bit about that film, because it was really something.
Well, yes, I learned a ton. I did interview Michelle Forcier in that film, who was in Matt Walsh's, what is a woman? And I have to be careful because I don't want to say anything I'm going to get in trouble for, because it was a really interesting interview, and there was a lot of control over what could be used versus what ended up on the cutting room floor. But when I was doing that interview, I, on the inside, was going, holy hell, what has happened to pediatric medicine? Because I had worked with pediatricians for decades, and I'm hearing the batshit crazy stuff coming out of the mouth. Can I say that on your show? Batshit crazy stuff. And I'm just going, we are in trouble. So that was kind of a real, like, oh my goodness. I had never spoken to, interacted with detransitioners. So we had 2 in the film, Hachi being one, and then another young woman who was anonymous and had her face and her name changed for her own privacy. So that I learned a lot from just hearing about people who were told this will fix everything, and to find out it didn't fix anything. And Hachi's just great. I mean, he's crazy smart. So kind and gentle. So behind the scenes, he was happy to find me, articles, studies, things that, just very, very helpful. I loved him. I fell in love with him. So, I learned that. We learned some interesting things because we hired a social media person to do marketing for the film after, and we were expecting because it went immediately onto YouTube for free viewing. And that was because the person who funded it just wanted it to be given away for free. So we, on purpose, we had it on other platforms because we were expecting it to be canceled. We were expecting to lose our whole YouTube channel and just have YouTube shut us down, which they never have. But they've never once allowed us to monetize the film. So it's been viewed by over 100,000 people, and we've made $13 off the film on YouTube because they won't let us monetize it because it's against their community guidelines. And their advertisers would not want their ads to be splashed up on this horrible, hateful kind of movie. So, but we did put it on Vimeo. We put it up on Rumble. We had our whole YouTube channel backed up just in case they just shut us down. So we learned that kind of stuff, which I'd never had to deal with that in any of the films that I'd made in the past, because there wasn't this big, we're just going to, have, people were telling me I should have security at my house and I should, put cameras everywhere because they're going to come after you. So, those are things that we learned in the making of that film, was just how the political climate is ugly. But I think really was just what has happened to medicine was my big take home.
What is your running theory about what has happened to medicine? Because you've certainly studied it from the inside out. And, I work in GenSpect, and we've been following the AAP story, and it just seems so inappropriate. And they just seem so kind of zealously committed to one narrow affirmative-only model for gender dysphoric children, to the point of silencing anybody who just wants to ask questions and seek reviews. That's all they're asking for. That's the kind of a radical kind of question that needs to be suppressed. What's your working theory of when you keep, because you keep on coming back to, and what is going on and what is going on? What is your working theory how has it lost its way so badly?
Yeah, well, I don't have like data to prove what my theories are, but I just have years of observation. We really shifted. I'm gonna sound like the good old days were so wonderful. Can we go back to the good old days? But I remember as a young nurse working with really truly amazing physicians. They would come into a room to examine a patient. They would touch the patient. They would talk to the patient. There was this real holistic, bedside manner. And I still remember, because I worked at teaching hospitals, so the residents would come in the morning, they would do rounds with the attending physician. The attending physician is the seasoned, years of experience, mentor. And, this one, he was a pediatric thoracic surgeon. He did all the heart surgery at UC San Francisco. And he was amazing. And these interns would rush and they haven't slept all night. They're dog-ass tired residents. They're working around the clock. They're grinding it out. And they have their head down and they just rattle up the chart. Well, the x-ray shows this and the blood work shows this and physical therapy says this. And he would stop and he goes, have you touched this patient today? Have you felt their skin? Are they sweaty? Are they cold? What color is their skin? And he would just wake them up but we become so data driven, right? We're data. I'm a data junkie. I'm always on my phone. Who tweeted this and has somebody liked we're data driven. So I think that was a shift. We stopped requiring ethics to be taught in medical school. Ethics is now an elective.
You don't have to learn ethics in medical school?
You can get through medical school without having to take any ethics class.
Really?
And back to the committee, the decision by committee, who's teaching the ethics class? Sometimes maybe it's probably a good idea that these students are forced to take ethics because the people teaching ethics are going to be, pro-transing of children ethics or, pro things that we don't really think are good and valuable and helpful to patients. So part of me says, well, is that really bad given the state of medicine right now? And medicine has really shifted to service. When I left, I remember my last job in nursing before I stopped nursing altogether. And I would quiz all the incoming interns. They come in at the beginning of a new year and you're going to be working with them for that year. And when they're in that year of their internship. And I would say to them, if you have a patient that comes in and they've done their Google search and they have, they say, doctor, I have this and I want you to order a CAT scan and I think I need to be put on this medication. What would you say to that patient? And it was overwhelming. They would just say, well, I would just do what my patient wants me to do. So it became more of, I'm just here to provide services. You just come in.
Is that the smoking gun? Is it that patients have become customers? That do all roads lead to that, really?
When I left clinical nursing, we no longer had patients. We had clients and we had customers. And we were service providers. We were no longer healthcare professionals. We were service providers. We have insurance providers. We have service providers. We have customers. We have clients.
That's where if we reverted to patients as opposed to clients and customers, do you think medicine would be in a better... would that be the thing that would bring us back to a more helpful model as opposed to a money-driven model?
Yeah, I think it would be helpful. I don't know if it would solve everything, again, because we don't have a unified, agreed-upon ethical framework. You have your ethics, I have mine. I think this is right. You have this. We look at what's happened to our professional societies like the American Academy of Pediatrics, the Pediatric Endocrine Society, where top down they're saying things that we categorically disagree with as far as the treatment when you think about, gender dysphoria in children. So I don't think just all of a sudden seeing them as patients will solve all that when we don't have a common shared ethical value, because I think we've lost that too.
We hope you're enjoying this episode of our podcast. We work very hard to maintain high quality content for this show, and we're grateful to Rhyme and Gen Spect for supporting us.
RIME, or Rethink Identity Medicine Ethics, is a non-profit organisation dedicated to improving long-term care for gender-variant individuals. Visit rethinkime.org to learn more.
And GenSpect is an international alliance of parents and professional groups whose aim is to advocate for parents of gender-questioning children and young people.
If you'd like to become a patron, you'll have access to weekly transcripts and special Q&As, and you can join our listener community.
Now back to the show.
When you guys, you're talking about this and I'm thinking about two things. One, I think what you said, Jennifer, really resonates with me, that there's a competing set of values and some of them have been kind of discarded or put into the background and others are at the forefront. So right now it's like patient autonomy is the number one ethical value. Whereas we're missing some of these important values that we have to balance. And I'm also just thinking about all the parents that I've met, right, who have been to doctors and had their concerns totally dismissed. In an ironic way, that is the paternalistic physician saying, I know best what your child needs. Actually, you're not my client at all. I'm not going to listen to any of your concerns. So it's hard to figure out how to do this because even when the doctor is trying to meet the needs of the child patient, for example, they inadvertently ignore completely the parent patient, who is an important part of that child's care. So it's just so messy.
It really is. And then we look at just how much parental authority is being undermined. So again, my past experience was we would move mountains in order to let parents do things for or not do things for their child that we were not in agreement with. So we would have Jehovah's Witness children in the hospital that needed a blood transfusion. But because it's against the Jehovah's Witness religion to transfuse blood, we would say, okay, well, we're going to give this child, volume through other kinds of liquids, saline or some other kind of, to try to honor, we would have Roma families that would be admitted to the hospital. And when you have a child of that background admitted to the hospital, you have 75 people that come with that child. And they would just park out in the cafeteria and in all the lobbies. And, other families would complain because there wasn't any place for their family to sit down, or where they would go to the cafeteria and they couldn't find a place to sit. But we would accommodate for all those kind of differences while still trying to provide the best possible medical, psychological, care for these children. But nowadays, parents, I live in California, where Ted Hudako, who's a dad out here who's been in a horrible custody battle, he's lost visitation. He hasn't seen his son, I believe, for 2 years.
Can you tell this story?
Yes. And Ted, if you're listening, forgive me if I get some of the details wrong, but, he basically is the father of 2 boys. And he and his wife, I don't remember the timeline of when he and his ex-wife separated and divorced, but somewhere during their time together, their one son, I believe it's their older son, started identifying as a girl. And Ted's ex-wife agreed, affirmed, said yes. Ted didn't agree, didn't affirm, didn't say yes. He lost custody. His child was put on cross-sex hormones against his permission, not even asked. He found out after the fact. And he has not, which is interesting, and he often points it out, he's not lost custody of his other son. So he's not deemed an unfit father, because if he was, he wouldn't be able to see either of his sons. But he's not able to see the one who's now identifying as a young girl. And I sat in on a couple of the hearings during the pandemic and they were all on Zoom, so you could easily just become a court watcher and log in and watch. And the judge opens the hearing by identifying himself with his pronouns. Everybody who works for the judge that's on the Zoom call has their names and their pronouns after. And you think, well, the fix is in here. He's not even going to get a fair hearing, when he's up against people who open a hearing by saying, hi, I'm Judge so-and-so and my pronouns are he, him. And so it's really tragic. And, in California, we're minutes away from becoming a sanctuary state. So other minor children from other states like Texas, like what perhaps DeSantis will do in Florida, that have said this is not treatment, this is not care, they'll be able to flee to California to get surgeries and cross-sex hormones. But I think, when you look at how we've shifted away from parents having the absolute authority, certainly we would intervene in cases of abuse. But, when it was a cultural thing, it was a religious thing, it was, a family, this is the way our family does things, or this is the way our family doesn't do things. Back then, medicine would really try to accommodate all those and not be disrespectful and not try to take your kids away from you.
Because a lot of this, the undermining of parental authority is something I've studied, and it's appalling when you watch how it's unfolded. But it seems to have come from an idea of trying to prevent abuse happening. You know what I mean? That and they kind of intervened, and they missed some dreadful cases of abuse, and so they keep on bringing in more and more policies, and then the policies get used against good parents who really shouldn't be getting. I'm not convinced that is anything except too many policies, not enough respect for the individual. I don't see that as anything to do with, unless I've missed something here, it's nothing to do with big pharma and people making big money or anything. It's a slightly separate issue that has joined in a perfect storm with this issue.
Yeah, I think it's just one added element to this perfect storm. Yeah. And we've lost our common sense.
I hear you.
Things that 10, 20 years ago, you would never think about chopping off a 14-year-old girl's breasts. You would never think about that. People would have thought you've lost your ever-loving mind. And now how quickly that's become, standard of care.
Yeah, it's like it's a weird overcorrection that has to do partially with like civil rights and LGBT politics and identity. It's a kind of a toxic empathy, like something that is distorted, which is very patient-led, meeting requests of individuals regardless of if they're mentally well or if they can consent. I mean, there's so much wrapped up in this that is very complicated. Is there anything from your studies of, I'm curious about what the fertility preservation knowledge you've amassed, like what can that tell us about gender medicine? Like, are there parallels there that maybe are underexplored or people aren't aware of, or like anything of value we can draw from one to the other?
Well, I think a couple of things come to mind. One is, back to what I said earlier on just the huge high failure rate of fertility medicine. Most embryos don't survive. Most embryos don't end in a live birth. Most embryos don't survive the freezing, thawing process. Same as, in the Silicon Valley where I live, all the women now here that work for high tech, they're offering fertility preservation to young women who work at Google and, Facebook, freeze and bank your eggs and save them for later and so you can have your babies when you're ready.
Could I just come in there because of what you're saying there, and you're going on to another point which I am very interested in. When you say most of it ends in failure, you're saying the embryos end in failure, but most fertility treatments for the women end up in success.
And don't end with success. So we're offering children. So I'm trying to make the connection so now we're telling young children before you change your sex. Again, I don't believe you can do that. But if you want to bank your eggs, bank your sperm so that you can have your children later, there's a lot of just false hope. They're given this.
What is the rate? What is the percentage? Because I thought it was fairly good. Now, obviously, I don't know anything about it.
Well, I can state U.S. data, and again, we have very liberal laws around this, and so it's about 25% success rate. So for every 100 IVF cycles, 25% of them will end in a live birth. Okay, but a live birth by definition is a baby's born alive. That doesn't mean a minute after they're born, they die. They're still counted as a live birth. So of 100 cycles, 25% of those will end in a live birth. So, which means 75% of those cycles they fail. And I've been tracking this data for 20 years. It's not, and sometimes you get a little bit better rates if you use fresh eggs versus frozen eggs, or if you're an older woman and you use a younger girl's eggs because your eggs are old. So some of that is nuanced, but just kind of that's a sort of a good frame for thinking that 75% of these cycles fail, and 25, and it's very expensive.
Oh my God, very expensive.
Like 100,000 and plus to go through a cycle of IVF.
Can I ask a different stat question? Let's say out of each 100 women that attempt to use IVF in order to have a baby, what percentage of those women will end up having a baby or more than one baby?
Well, they're lumped into that figure I just gave you. So the CDC is where the data comes from, and the CDC publishes an annual report on all fertility clinics in the United States, and they are compelled to report. There's always some that don't, and then they get in trouble because they didn't report their data. We can have a whole conversation about how they probably fudge their data because you want to show that you have really good success rates so people will come to your clinic, right? So they probably, wink, wink, that didn't fail, but we don't have to count that one, so they take all this data, and this data that is 100 to, the 25% figure includes women who use their own eggs, women who use their own eggs fresh, means they came right out of their body. They fertilized their fresh egg. Women who bank their eggs and put them in the freezer, and then they came and got their frozen eggs and they use frozen eggs. Women who used egg donor eggs from younger women that were fresh or frozen. So all those kind of, stratifications are in that data. And usually the CDC will break it down into like fresh eggs versus frozen, because there's a lot of interest in, do fresh eggs work better than the frozen ones, because all these women are now banking and freezing their eggs. And it is a game because everybody wants you to do it, right? Because then they get money.
Yeah, because I'm thinking about cycles, and I'm thinking, like, let's say you have two women. One did one cycle and successfully got pregnant or successfully had a baby, and then the other woman maybe went through 4 or 5 cycles of IVF. Then proportionally speaking, it looks like out of every 7 cycles, only 1 works. But like, it's that woman perhaps was, for some reason, her eggs weren't as viable or something. So I guess that's why, because this is so foreign to me, I'm trying to figure out, like, not only number of cycles, but like in terms of the individual people seeking out these treatments.
Yeah. And most women, when they go through one cycle, because it is very expensive and it's very rough on your body, and we didn't even talk about the cancer risk, and, but one cycle, they'll get many eggs in that one cycle and make many embryos.
Okay.
Because you don't want to just go and take one egg and try it, and then you have to go back on the fertility drugs and then have the egg retrieval. And so they'll just take a bunch of eggs, make the embryos in that, but it's still one cycle.
Gotcha. Okay.
And that's why most people who do IVFs, they presume there's going to be a few goes because there's going to be some failures. Yeah. And I don't think people have a major issue with that they accept that that's the rate, and they accept that's the...
Well, these are people that, when we say most people, these are privileged people that either have insurance that covers this or they have the financial resources. If you're a low-income woman or an uninsured woman and you're struggling with fertility, we don't offer anything to you. I mean, this is a private pay out of your pocket kind of. And even most insurances in the U.S., I think in Europe it's different. They'll offer the National Health Services will offer a few cycles. They don't offer unlimited. I think and I think it's regulated too by the age of the woman, because if a woman is older, I think she gets one chance, because the failure rate is even higher just as we age. It just happens. The reality of our biological clocks.
Mm-hmm. And do you not think they should be offering it so easily? Do you think it's problematic fundamentally?
Well, I think we know it's problematic. It's not without health risks. I mean, there are cancer risks that are linked to fertility drugs. One study that I published in the medical literature with 2 of my colleagues, actually, it's not a study, it was a case report of 5 otherwise healthy young women who sold their eggs. and went on as young women to be diagnosed with breast cancer. And there's a few things we know. We know that young women don't normally get breast cancer. It's a cancer that strikes us in our 40s, 50s, 60s. And we know that egg donors are screened out if they have a history of cancer. Nobody wants to buy eggs from a woman who has a history of cancer, especially breast cancer. So these were women that were selected to sell their eggs with no history whatsoever of breast cancer. And we go, why is it that these 5 women, and the only thing they had in common was they took high-dose fertility drugs to become egg donors, went on as young women to develop breast cancer? We know that IVF can be rough on your own fertility. We're now seeing, because we've been at this long enough, we're seeing large studies of children created through assisted reproductive technology that have higher rates of certain genetic disorders. Beckwith-Wiedemann syndrome is one that comes to mind. There's another one I'm blanking on. There are certain heart defects, and we don't know if it's directly because of the assisted reproductive technology, but we're just seeing now that we have larger samples that the common theme is that these are children that were born through assisted reproductive technology. Obesity is one thing that we're seeing, children born of but again, we don't know, is it the technique?
Mm-hmm.
Or is it there's some underlying fertility problem with this couple that was struggling to conceive because there was this problem? And that's sort of an evolutionary thing, that we sort of ignored it and we assisted them in conceiving when perhaps nature, evolution, whatever you think, maybe you didn't have this couple, having fertility in their future. I tried to talk to Colin Wright about that, and he's like, it's not my area. And I'm like, but there's a lot of people in evolutionary biology that are really critical of assisted reproductive technology because we are messing with the normal evolutionary cycle and processes of how and who conceives, the survival of the fittest kind of thing.
Are the medications, are they kind of hormones that impact our endocrine system? Or like, just for a layman's explanation, like, how do these medications work?
Yeah, well, let's talk about the egg donor, because I get exercise. Egg donors are always put on Lupron. And we go crazy when we find out about kids being put on Lupron. I mean, almost the first drug, if not the first drug. They're also oftentimes put on oral birth control pills, but they're put on Lupron because we're trying to put them into a medically induced menopause. We're trying to medically castrate them, medically quiet their ovaries from doing what the ovaries are to do, because we're trying to synchronize her menstrual cycle with the woman who's going to be receiving her eggs. So you've got this woman over here is going to be getting the eggs, and they're on different cycles, right? And ideally you want to time those, so they'll stop the egg donor cycle with Lupron. Then she's switched to some gonadotropins that put the ovaries into hyperdrive, that force the ovaries to create lots and lots of egg follicles and eggs. And then she's put on HCG, which is hormone chronic gonadotropin. I just call it HCG. I forgot the big name for it, which allows the eggs to release from the follicle. So when they go in surgically to remove them, they're easy just to suck them all out. So similar drugs for different uses, but yeah, egg donors are put on loop. Sometimes surrogates are too, but not always, because they're maybe not so concerned with the synchronization of the cycles because they can freeze the embryos or.
And have you an issue that the donors and the surrogates aren't aware of the massive risks they're taking?
No, and we haven't done any of the studies. It's another dirty little secret. Same with children. Because what the studies we've done on these drugs on women have been in infertile women. So we know about these cancer risks in infertile women who take fertility drugs, like Gilda Radner. I'm old enough to remember Gilda Radner, the famous comedian on Saturday Night Live. Most people don't realize Gilda Radner died of ovarian cancer. She was an infertile woman. She and Gene Wilder did, I think, 6 rounds of IVF and never got pregnant. I was on the phone yesterday with a doctor who's an affiliate with Segum. You guys know Segum. And she has a friend who did fertility IVF, took fertility drugs, and a few months later, she was diagnosed with breast cancer. And her oncologist said to her, I'm sure it's because of all the fertility drugs you took. But when we look at the egg donor, because she's not a patient, we've never done any studies on what happens when you put these healthy women who have no underlying fertility issue on these powerful drugs. And that repeated effect. So when you look at the professional society, the American Society of Reproductive Medicine, they recommend that a woman doesn't sell her eggs more than 6 times. But it's not based on any studies. It's not based on any data. It's just more, we don't want this woman to have 50 kids out there, that are all from her. Kind of like what we see with sperm donors who find out that they've got 400 kids out there because they've just been given away their juice. So, but yeah, there's no study. So egg donors are told, their informed consent is there's no risks. They need to be told there's no risk because we've never done the studies, so we don't know what the risks are. But in my film Exploitation, 2 of the women took Lupron, had massive strokes. What did the FDA just slap Lupron with for violation or warning for puberty blockers? Pressure in the eyes, pressure in the brain, pressure. What do you think a stroke is? So 2 of the women in my film Exploitation had massive strokes related to their Lupron. Both of those women were rendered infertile because of their massive strokes. And we know as women, what controls our menstrual cycle? Our pituitary gland, which is in our brain. So when they had massive strokes, their pituitary gland. So one of the women laments in the film that she will forever have to take fertility medicine because her pituitary gland was destroyed with her stroke.
Why do most women become donors?
Money. I mean, the profile is college girls, a lot of debt, and they're all over. My two oldest daughters went to the University of California, Berkeley, and they used to come home with the Daily California, the school paper, and there would be ads for $100,000. $100,000 for an elite donor. We want a really smart girl, really. So, and it's all, the marketing is happy. I mean, look at the gender marketing. You see these smiley girls with their pink shirts on Planned Parenthood, get your testosterone here. Be an angel. Women are prone to being sympathetic for people who are struggling to have a baby. I'm not using my eggs now. Might as well help somebody else with them. I could sure use the money.
I've heard this from some young people. I mean, young people who are considering maybe this would be an easy way to make extra money. And I'm not really well versed in this, but I know, speaking with a couple of young trans men, their philosophy was like, well, I don't need these eggs anyway, so maybe I will donate or sell them. And I'm curious about whether or not there is a push to encourage, quote, trans people to sell their eggs for that reason. I mean, this is an interesting intersection that I never really clicked with me before until I heard you saying this, and I'm thinking about these conversations I've had.
Yeah, I haven't heard if that has been an uptick and like, oh, okay, well, if you're going to transition to being a man and you don't want to preserve your fertility, can we just go in and rob you of all your eggs and sell them on the open market? I haven't heard that. I mean, part of me thinks with the bad actors that we know are out there, I'm sure there would be some less honorable people that might think that's a good way to go. I mean, just Google World Egg Bank. There's one in Arizona. They're trying to be the providers of eggs for the world. And just, they have just bats and bats and bats of eggs. And the scientific researchers need eggs, right? So they can either, sell their eggs to scientific research or sell their eggs for.
How many eggs did you say there are? You said so how many embryos at the beginning of this? You said
in the U.S. we have over 1 million. We have more. You have more in the United Kingdom only because that's where Louise Brown was born, the first test tube baby. So the United Kingdom is where this whole test tube baby science happened. With the 2 scientists, Watson, Steptoe, and I can't remember the other guy's name. But yeah, there's quite a few more in the United Kingdom. I think they have over 2 million in the United Kingdom. But
oh wow!
But yeah, these kids they're being sold this is going to fix you. This is going to solve your problems. And oh, by the way, we can bank your fertility so that if you later think you want to have children, it's just a racket, and it's just not good medicine. It's just a money grab.
And ideally, what would you like these kids to be told? You know what I mean?
I loved it because, and again, when you interview people for films, you hear people saying it and you're like, did that make it in the film? But I interviewed Paul Hughes for Transmission. And I remember he said this and it really hit me. And I think it didn't make it into the film. But he basically said, and I thought, that's brilliant. It's so true. We have so much else to offer these children. right? It's not like we either have to block their puberty, put them on hormones and race them off to the sexual, reassignment surgeon, or they're going to kill themselves, right? That's what the people that we're fighting like you to say. We either have to do all this or they're going to die. And he was just like, there is so much medicine can offer these children, whether it be good psychological counseling, therapy, family counseling. If I don't know if you guys have children or not, I've raised 4. Find out what's going on in the home. Find out what's going on in the school. Find out what's going on in the community. There's this holistic approach to what is going on with this particular child. And it's not a one size fits all. This might be a child who's just awkward. This might be a child who's being bullied at school. And we're just my oldest daughter was bullied at school. And I didn't find out for like several years later that she had been bullied because she just didn't come home and let on, and the teacher was the bullier.
Oh.
And so the teacher, of course, didn't let on that my daughter was being bullied in school because she was the one that was doing the bullying. So there's just so much we can offer these children. What's going on with the marriage in this child's life? Their parents. Is this an abusive home? Whatever. And I'm not saying that these children that are struggling are in abusive homes, but there's so much else that we can try to figure out and offer these children. And it was Fruz that sort of turned that light bulb. It's either this or that. There's so much that we have in our toolbox.
That's a really hopeful way to wrap up our conversation, because I think there is so much we can offer, and we're really grateful for you coming on the program and for talking to us about your films and your interests. It's been really fascinating and illuminating. So thank you, Jennifer.
Oh, I've had a really good time, and I'm so happy to finally get to talk with you guys. I've admired you both from afar for so long. I feel like I'm a little fangirl getting to be with my starlets.
Thank you very much. Kind. Likewise. Thanks, Jennifer. Take care.
Thank you. Have a great day.
Thanks for joining us this week on Gender, a Wider Lens. This podcast is sponsored by Rhyme and GenSpect, and listener support means a lot to us. The best way to help is to subscribe and review us on iTunes.
Follow us on social media, and if you'd like to become a patron, you'll have access to weekly transcripts of the show, special Q&As, and you can join our listener community. Just go to our Linktree. That's linktr.ee/widerlenspod.
Our discussions are for educational purposes only and are not intended as a substitute for mental health services.